Good evening, everyone. Thank you so much for being here tonight. On behalf of the Los Alamos Community Foundation, the League of Women Voters of Los Alamos, and the Anchorum Health Foundation, thank you for joining us for tonight's panel discussion, Health Care in Northern New Mexico, a Changing Landscape. My name is Felicia Orth, President currently of the League of Women Voters of Los Alamos. I'm honored to introduce tonight's panelists and facilitator. Lillian Montoya is the Senior Vice President of Christus, New Mexico, and President and CEO of Christus St. Vincent Health System, a native New Mexican with more than 30 years of leadership experience. She has led Christus St. Vincent since 2018, guiding the organization through significant cultural and quality transformation, including earning 5-star CMS recognition and national workplace honors. She also serves on several statewide boards, including the New Mexico Hospital Association. Dr. Eric Ketchum is an emergency physician with Presbyterian Healthcare Services and medical director for addiction medicine at Presbyterian Espanola Hospital. Board certified in emergency and addiction medicine, he leads substance use disorder treatment initiatives across the state and has testified at both the New Mexico legislature and before the U.S. Congress on addiction and emergency care issues. Brenda Romero, RN MSN, is Chief Executive of Presbyterian Espanola Hospital. With more than 40 years at the hospital and over 30 years as a nurse, she brings deep experience in rural health care leadership, quality improvement, and behavioral health advocacy throughout northern New Mexico. And Dr. Madhavi Garamella is board certified in internal medicine and endocrinology, diabetes, and metabolism, and is a diplomat of the American Board of Obesity Medicine. She practices in Los Alamos and has served the community for 20 years. Following her medical training in India, residency, and fellowship at UNM. Thank you, panelists. And our facilitator is Brandy Weiss, the program manager and Anchorum fellow for the Los Alamos Community Foundation. Brandy is also the assistant speech coach for the Los Alamos High School Hilltalkers. Brandy.
Good evening, everyone. Hopefully you all can hear me from the back. Please let me know if you can't. Okay, great. I am truly excited to be here to facilitate this amazing event. Thank you all for this incredible turnout. I'm so happy that this room is almost entirely full. Let me briefly explain to you how tonight's session will flow. Our panelists will each respond to 3 prepared questions, and we've set aside approximately 25 minutes per question for that portion of the discussion. We're fortunate enough to have 2 outstanding student volunteers with us, Amelia and Sophia. They're here at the front, from the Los Alamos High School Hilltalkers speech and debate team. They will be serving as our timekeepers and will let me know when it's time to move on to the next question so we can keep the conversation moving. They will also be collecting note cards from the audience throughout the program, and at the end of our moderated discussion, we'll reserve time for audience questions. I will review the submitted questions and select several to give to the panelists to talk about. We're looking forward to a thoughtful, engaging, and community-centered conversation this evening. After the 3 questions, when we get to the audience questions, please raise your hand if you have not already written down a question for us, and one of our students will go over and hand you a note card so then you can write a question and then bring it up to me. Yes. Yes. If that's the case, you can please let one of the students in front of you know and she can write it down for you. Yeah, there'll be no problem at all. Thank you for letting us know. So to begin the panel, let me hand you all the mic. I will ask the first question. whoever wants to pick it up can pick it up. There you go. Whoever wants to do the first. And for our panelists, please let me know if you need me to repeat a question at all. I'm happy to do that as many times as you would like. Perfect. And our student timekeeper is Amelia. Sophia. She's in the white vest. And she'll have note cards to let you know how much time we have left. So our first question is, what challenges may arise for you or your institution in the next 1 to 5 years for delivering health care?
Thank you, Brenda. Well, it's so nice to see all of you coming out on an evening to learn more about healthcare. We need to figure out how to fill your lives with other joy, let me tell you. For a lot of hospitals, many hospitals, and Brenda's going to probably say she concurs, but the pressures that we experience are probably very similar to those that you think about each day as you try to navigate the healthcare world. Everything from workforce challenges, which are very real for us in terms of recruitment and retention, certainly the financial pressures that we experience every day, from shifting reimbursements, payer arrangements that are challenging, national decisions around who can qualify for Medicaid and who doesn't, who can receive care and who doesn't. We're having to make decisions every day about how we can deliver the services that matter to a community in that shifting environment, and it's incredibly challenging. Technology. We're having to encounter and experience more integration around AI, cybersecurity, and privacy challenges, and how do we navigate that so that you feel safe in getting care. And then perhaps at the very top of your list would be access. And every hospital, because of those financial pressures and the regulatory environment, is every day having to make tough decisions about what services can we reasonably deliver in the community that meets the access needs, what can we reasonably grow, and what can we sustain. And those challenges, coming out of the pandemic, we had some very unique challenges in that moment. And I would say today the challenges are different, but they're equally difficult to navigate. We have to continue to work as partner health organizations to figure out how we take care of a whole community. And I would say that one of our biggest lessons through that pandemic experience was that a very deep realization that we are an entire ecosystem of hospitals that are taking care of an entire ecosystem of humans. And how can we best do that to make sure that everyone feels that they can receive access to care, quality of care, and a patient experience that allows them and creates that safety environment where they want to come back for more.
And I'll add to that, as the population gets older, right, we require more care. And so it's hard for all of us to provide the care that is needed. So we at Presbyterian Espanola Hospital are a smaller acute care facility. And so we stabilize patients, but we can't provide, put it closer, we can't provide all the care that the patient needs at our facility. So then we transfer him to Lillian and her team. And we support each other each day in, trying to decide who needs to go there. If she's full, who could come to our place. If we're lacking equipment or supplies, we borrow or lend from each other, right, to include Los Alamos Hospital. And so all hospitals help each other out, trying to figure out what's best for the patient and how we can navigate that. The pressures related to the finances, you all know that when a new year comes and there's changes to the health plans that we're all signed up for, and what it covered last year might not be covered this year or might not be covered as well. And you need a prior auth for something that you didn't need a prior auth. And it's frustrating, not only for you and the community, but for us, right? And the really good thing is that we have employees who work really hard to help the patient navigate healthcare and get you what you need, right? So having conversations with the health plans or coaching you on what to do next or where to go or what to say to make that happen. And being a not-for-profit allows us to provide the care anyway and then we'll figure it out later, right? So coaching our teams to focus on patients and what they need, and having clear conversations so that we can all help each other out.
So to get into some more, I guess, specifics, challenging in my environment clinically. So I do work as an emergency physician, but in my primary work is actually as an addiction specialist and growing our addiction medicine service line. Oh, sorry.
I'm just watching the back.
Okay. So in trying to grow that service line, and it's all about being able to meet a tremendous unmet need it's been unmet for a long time. But this is a patient population that overall tends to have what we call a poor payer mix, right? In other words, predominantly Medicaid, a lot of folks who are uninsured, and this requires an investment, in the hospital to be able to provide those services. And so we're very dependent upon making sure that Medicaid continues to get funded, and that we don't, have that kind of funding pulled, as well as for folks who are relying on the market exchange, et cetera. So we're very extremely vulnerable to changes in government funding, and also, it's grants that have allowed us to fund at least the brick and mortar part of our expansion, as well as being able to recruit physicians. And so if those type of funding programs go away, it directly impacts our ability to care for the most vulnerable of our patients.
Yeah, so, I'll just have to speak on behalf of our patients, because they talked about the hospitals and in terms of the clinic. So specifically for Los Alamos, we worry because it's very difficult for us to recruit physicians, as our clinic, for example, has been trying to recruit physicians for at least a couple of years. And unfortunately, we have people who want to come, but then they look at the housing prices in Los Alamos and then they decide that they cannot come. And so we have that problem. It's difficult for us to recruit staff because, again, staff cannot live in Los Alamos, and most of the people live off the hill. And so day-to-day operations become hard sometimes if there's a snowstorm or other things like that. So I'd say that would be an operational thing. In addition, we have the complexity of billing, and it's the same thing like you guys in terms of Medicaid. Medicare, for example, has cut costs, and so they did a 2.8% reduction last year, and which becomes very difficult to sustain because Los Alamos has an aging population, and most of the people are on Medicare, and we do want to keep our doors open. We do want to be able to take care of patients, but then such costs, our reimbursement rates going down, but costs of business going up become hard. And lastly, because of all of these problems, it's hard to retain people. So I worry about our patients. For example, like visiting nurses has closed down. So we don't have people who can do in-home physical therapy. And my patients who need hospice care, or my patients who need equipment. There's no place, for example, in Los Alamos that they're able to get all of these things. Even diabetes shoes, for example, people have to go off the hill to get things. And so on a day-to-day basis, I think that becomes really hard because we want to do the best for our patients. I think everybody in Los Alamos deserves the best care, but it's hard if they have to go somewhere else for their imaging study, somewhere else for their equipment, somewhere else for physical therapy, somewhere else for other things, oxygen. It's so I think those are the day-to-day frustrations that make it hard because we want to do a lot of things, but then we are restricted because of prior auths. We are restricted because of facilities. So I'd say that those would be the biggest challenges, and in the next 5 years, which I hope will get better.
Okay, we will move on to the next question that we've prepared, which is, what do you or your institution do to provide health resources to underserved populations?
Okay, well, I can get started with this one. let's see here. So we work with patients who don't have a payer source to help them find a payer source, sign up for one. We provide food for patients. We have a program that when the patient comes to the hospital and they assess the social needs of the patient, the doctor can write a prescription for food, and then every Wednesday we pass out food in the lobby for those patients that received a prescription. With Dr. Taylor's and maybe others in this room's help, we're going to be providing cell phones for patients in the renewal clinic who don't have a cell phone, so that we can communicate with them in between the times when they're coming to the renewal clinic to see how they're doing and to see if we need to move up their appointment. Dr. Ketchum can say more about that. So there's a lot that we're already doing to help patients, even if it's trying to figure out how to get them somebody to donate their money for the medications if they can't afford the medications. There's churches in town in Espanola that provide money for that work. So again, it's identifying what the need is, and then working either through ourselves or our employees or the community to help them get what they need.
So as a nonprofit, very similarly, we set aside resources to basically fill the gap. So this last year alone, we invested about $40 million in uncompensated care. So this would be for patients that either don't have insurance or are underinsured. An additional $20 million for partnerships in the community where we fund safety net nonprofits to help us meet the needs of the community of people that we can't always get to. But those are outside the walls of the hospital unless they're coming within. And then we have a HUGS program, for example, it allows us to basically work with those individuals that tend to be the high utilizers of an emergency department service, so we can help connect them to community resources after they've received health care, so that they don't have to return back to the emergency room. And a lot of times that assistance is connected to housing, getting their medications, transportation, which is a significant issue in northern New Mexico. With our aging population, you'd be surprised the number of people that are in the HUGS program that are of an older demographic, and their biggest challenge is living in isolation, not having family that can or friends that can get them to an appointment or help pick up food and grow, for food insecurity issues or even their prescriptions. So the HUGS program is something that we've had now in place for about 11 years, and it made a very profound difference in the lives of many people who are no longer constantly having to return to the emergency department for their system support, if you will. We also provide spiritual care support for all the denominations in our community, those who practice the faith and those who do not, so that they have someone that can see them and hear them and be available to them when they're going through a cancer or any type of experience. We're also extending that chaplain service into our ambulatory clinics, because we know that when you come to a hospital, that is not the only time when you want to be connected to your faith. Sometimes it's when you're going to a clinic appointment and you want to talk to somebody about the challenges that you're facing. And so we layer all of that into the care that we're providing to the community. And then, of course, in our partnership with Anchorum St. Vincent, participating in the Donor Advised Fund and other programs alongside them to invest in the community outside the walls of the hospital, so that most people don't have an inpatient experience, right, or an emergency department experience, but they do have a clinic experience, or they do have a housing challenge. And so we want to be part of that solution. And then those are the cases where we lean on the experts in the community through resources and talent to help fill that need.
Thank you. So the clinic that we've recently expanded, I mean, by definition, is serving an underserved population, right? So our although we've been providing these services now as addiction medicine to the community for over 7 years, and run an inpatient addiction medicine consultation service as well, but the decision to actually use a kind of I would say a kind of a prime real estate chunk of the hospital and dedicate that to our substance use disorder patient population has been an investment both in labor and time and gathering those resources and fundraising and grant development, et cetera. But we really feel that if we can treat these very vulnerable patients, not only are we helping a patient population which has been underserved for a long time, but treating patients with substance use disorders it's really treating an entire family. And when you have a family member that has an opioid use disorder or an alcohol use disorder or using cocaine or methamphetamine, it really just tears a big hole in your family. It leaves kind of a wake of destruction. And so often when we talk to our patients and families, they come together and they're just so grateful that they've gotten their family member back, that they've been lost in this wilderness that was so consuming. So that's, I guess, our most recent, example of what we've been investing in. So.
Our clinic is a small clinic. We don't have funds other than what we have. So for us, our community events are mostly trying to organize things like diabetes run and heart run, and the Heart Council, we used to be part of the health fair and things like that. So for us, it's being available to our patients and taking Medicaid.
Perfect. And then our next question is for you all: what laws passed in the most recent legislative session will impact healthcare professional shortages? There's two parts to this question. And then, so this one may be a repeater for you all. What additional laws could help address these shortages?
Well, Lillian is the expert at this.
Brenda's pretty expert at this part. So you all read the article in all the papers this last few days, but medical malpractice. This was the most significant issue that we needed to address, and thankfully, Representative Chandler, if for any of you did not see her in the Senate Judiciary Committee, you can still watch it. If you go to the legislative website, she will knock your socks off. She will knock your socks off. She was formidable and steely and determined, and it was impressive. And I will tell you, for the ladies in the room, the ladies drove that bill on the Senate and on the House side. And they really leaned into each other to make this an issue that no one could walk away from. And the governor was determined to call a special session if we were not successful. So this biggest issue is around the punitive damages, and that there are caps. And they are tiered for independent and outpatient hospitals and for hospitals like Los Alamos Medical Center and Presbyterian and St. Vincent. But that cap on punitives for us is at $15 million. It was uncapped before. This was a significant issue because punitives are punishing for willful conduct, right? Bad faith, reckless behavior. And so this medical malpractice bill that has to be signed within 20 days by the governor not only defines what punitive is, but it also calls for the time at which it can be considered by the courts, and then of course tiers the punitive damages. And that is probably one of the single biggest reasons why we had challenges around recruiting physicians and other providers, because they did not want to put their license at risk in this state. We actually St. Vincent lost a plastic surgeon a year ago, October, who had made the decision to slow down retirement here and wanted to practice half-time with us, and had actually accepted a letter of intent, and a month later came back and said his financial advisor and his attorney advised him to pull back because why would he put his career at risk at this point? It was a very real issue. And so, but it's not the silver bullet. There are other things that need to happen to really transform the environment for healthcare delivery in the state. Everything from the loan repayment. Representative Chandler also was behind that bill. That'll actually be substantial loan repayment investment for people that want to practice in New Mexico, up to $300,000, which is amazing. But we'll need to get other compacts through. We did get the physician compact through, which is sort of it's a faster path to licensure in the state. The doctors still have to go through credentialing and privileging with the hospitals, but allows for a faster pace at which to do that. Social work compact also got through. but several of the other none of the other compacts got through. But the solutions are going to be varied, as I just mentioned, but it goes beyond healthcare, quite honestly. I think our opportunities in New Mexico are around economic opportunity and creating more economic vibrancy in our communities. So our young people want to stay and work, live, and play here. So they want to go to school and stay and practice here, where we have more small businesses and mid-sized businesses that have commercially insured persons so that they can take advantage not only of the healthcare systems, but they take advantage of the schools and they buy houses. Housing's the big challenge, so we still need to address housing opportunity in the state. It's not just affordability, it's accessibility to housing and all types of housing. And so it's the healthcare solutions go beyond healthcare. It's about how do you create strong communities where they flourish, and how do we do that together? So there is more work to be done, but honestly, this was a bold move, and anytime you see Representative Chandler, she's not a hugger, but she's got a grin now, so you got to own that and lean into that.
And so when you ask what else do we need to work on, we need to work on improving the Medicaid reimbursement. So even though New Mexico, is working on that, the federal government is reducing that, and it's not an equal balance, right? It's far less than what we need it to be in order to be successful financially. In supporting the residency programs, we need more residency programs in the state of New Mexico so that we can keep more doctors now that they don't have to worry about medical malpractice as much. The behavioral health funding, we need that to improve, and the rural healthcare funding also needs to improve. So a lot related to funding the work. I think sometimes, people think, well, they're making a lot of money, and we might be charging more than we make, but at the end of it all, getting healthcare costs a lot of money, right? All the regulations that we have to comply with, all the medications, the equipment that we buy. I mean, we can pay $40,000 for one bed, right? A bed for an OB patient, right? So it costs a lot of money to do this work, and even though the charge might be higher than what you're going to be reimbursed, and then there's others who don't have a payer source, so it all kind of balances out.
I can't add a lot to that, but would say that some of the expenses that I think much of the public doesn't appreciate, the amount that hospitals spend on IT is you'd be floored to realize how much that is. And we've now become so dependent, just as many of you are in your professional work and in your personal lives, right? Well, at the healthcare, the way we expect to have data at our fingertips now and to be able to integrate with our other facilities, and we're fortunate that Christa St. Vincent, for example, uses the same electronic medical record that we do. So we have patients that bounce between our facilities, but we can actually look up their records and lab results and imaging studies, so we don't have to repeat them when somebody comes to our hospital. We're actually able to see, I see where Christus, just last week you just had this imaging study, you already did this. So, but the threat of cybersecurity, for example, when we go into, I'm just an upgrade of our EMR when I'm working in the emergency department, and somehow I have the best luck because I only work night shifts on weekends in the emergency department, which means I get to live through most EMR updates. But when the electronic medical record goes down for 4 hours, and I mean, it's just stunning, like how everything comes to a halt and we go back to a paper world and how we communicate with each other and getting things done. And so it is, just as you've experienced these in your businesses, amazing percentage of the cost just goes into IT now, and that's in addition to integrating that with imaging studies, lab results, how we communicate with each other.
Yeah, I mean, as a small clinic, these are the bills, of course, that was there. which we are hoping will allow people to want to come and practice in New Mexico, because it has been hard for us to get our patients to see specialists. It takes about a year. So, I mean, these are all the usual problems. And so I have nothing to add about these three important bills, the HB 99, the HB 66, and then the compact bill. I hope that eventually they'll be able to work on prescription drug prices also, because there are many common medicines that should be available to patients, but unfortunately they're not. So, for example, insulin and other important drugs. So hopefully those common medicines that people should be taking, it will be easier to get for them without us having to fight in terms of everything. It's like they want people to get worse before they get better. And so you have to get worse. Your A1C has to be 9 before I approve you for this medication. So those are the fights that we fight on a day-to-day basis. And so so as far as bills and proposals, I think hoping that drug costs come down and we have to fight less for our patients would be another thing that I'm hoping will happen in the future.
If I could add just one thing to that, and this may sound obscure to a lot of you, but we actually have a lot of challenges being able to provide life-saving medication to treat substance use disorders in the state. These should not be expensive medications, but because of well-intended but really kind of poorly thought out federal government policy that absolutely impacts us locally. And these are things that you would think would have been great, like the opioid settlements. Well, there was a flip side to that happened because of not a reverse of long-standing federal policy that creates tremendous shortages of life-saving medication called buprenorphine that we have to deal with. So we're always trying to somehow kind of way to get this through the legislature. But these are bills that are hard to pass because it doesn't draw the attention sort of the rest of the medical community, but yet we know that it's vitally important to our patients.
Thank you guys so much. I want to say thank you to the panelists for your thoughtful responses for these 3 pre-done questions. I think we were going to spend the rest of the time doing the audience portion of the event because so many of you showed up that we wanted to make sure that there was enough time for quite a few questions from the audience, because after hearing what our lovely panelists have to say, I'm hoping that sparked some inspiration. Our goal is to move through the rest of the questions. We'll have the responses be 10 minutes each for each question. The students will still keep time. So if you are interested in writing down a question, please raise your hand and one of the students will walk to you and give you a note card so then I can take the question and ask the panelists. We already have 2 questions done, and once you're done writing the question, please raise your hand again and they'll come and grab it. And so I will wait till one of them comes back before I ask the next question so that they can keep time, or I can keep time on this question. I'll do that. Okay. So our first question from the audience is, what, if any, are there plans for a freestanding ER or elderly services? I was like, please feel free.
We have 2 primary care physicians that are boarded in geriatric care, so we do have that in the clinic, but we don't have any plans for a freestanding ER.
We have a healthy aging clinic. We have a geriatric trained, fellowship trained provider and team as well. And that has been, we've seen significant growth in the patient volumes that are coming to that clinic. We don't have a freestanding ED plan, but we have other plans for Los Alamos. We can talk about that in a little bit. But honestly, our entire region needs more access to memory care, skilled nursing facilities, behavioral health support for aging populations. We have very few places in which to refer, and certainly not enough slots to provide that care. Home care is another good example where we have a lot of challenges in the region.
just as an emergency physician to address the issue of freestanding emergency departments. So Presbyterian actually has, I think, 4 or 5 in the greater metro area around Albuquerque, and these are combination facilities where, depending on how you're triaged, you go either into the urgent care, the low acuity side, or into the emergency department side. And in that larger population center, and I will say this, as long as it's partnered with a hospital, I think that it could be a really good extension of care. But in some parts of the country, freestanding EDs have sort of popped up as almost really kind of a money siphoning kind of process where they limit the insurance that they'll take and really limit sometimes some of the services and therefore it actually negatively impacts hospitals' ability to survive. So freestanding EDs really have to be carefully who opens it and how they're implemented and how they're part of a larger healthcare system.
And I believe, and if I get it wrong, Lillian will help me. I believe that the state of New Mexico does not provide a license just for an emergency room. You're applying for a license for a hospital in a minimum of 8 beds. And so because the freestanding ERs are associated to Presbyterian, they take admissions to Presbyterian. And I know that there's 2 other ERs that are privately owned in Albuquerque, and they're not associated to anyone. And they, if they can't find anybody to take them, they have to figure out how to take care of them until they find a place to send them to.
Awesome, thank you. So the next audience question, thank you, is telemedicine valuable, and is it a net positive for you all?
No, for us, it's extremely valuable because we have a lot of people who live very far away, and we just have to see them for lab results or change in medications, etc., or they're having some kind of a crisis. So it's extremely helpful to just say, are you available for a video visit now, and get onto the phone with them. Or if we have a cancellation in our schedule, we're able to immediately see them. So I find, at least for us as a private clinic, telemedicine is extremely helpful because it allows us to give prompt care to patients rather than having them wait, and it is a net positive.
So I would say the same for our clinic, and a lot of our patients really lack transportation, and particularly in northern New Mexico, where Espanola Hospital serves a very large catchment area. And for our clinic, because there's so few clinics in the state that are dedicated to treating substance use disorders, we have patients that come from a long way. We actually have some patients travel from Albuquerque to come to our clinic, but we have patients who come down from Raton, from Taos, beyond Taos. For a lot of patients come up from Santa Fe and from Los Alamos, but a lot of our particularly rural patients, particularly those who are lacking in resources, have transportation issues, we rely on the telemedicine a lot to be able to connect with them. One of our challenges, though, is they live in an area where there's no internet access, and often where there's really poor cell phone access. And so then we're trying to speak to them just over the cell phone without having a good internet connection. So one of the things comes to the question about partnering. We're working on our relationship with some of these smaller independent clinics in northern New Mexico, such as Las Clínicas del Norte, where the patient can often get to that clinic because that's close enough to their home and it's a small clinic, but they can get there, but they can't necessarily get all the way down to Espanola. So working with them so they can just come in and use the Wi-Fi, just so they can come in and be able to talk to us on their cell phone, or if they don't have a cell phone, they can just make a simple device available so that we can see them. We do have to see people in person, but throughout my day, I have multiple patients we're seeing in person, and those also who are seen by telemedicine. And just a second, Dr. Madavi, I was afraid I'm going to mispronounce your name. ability to actually move our schedules. So we have patients, we're running behind, and our staff will call the patient, say, we're running behind. Since you're going to be seen on telemedicine, if you want to go run some errands, we'll call you back, and allows us to keep the flow moving as well. And I think it's really good for our patients, and so we don't have them tied to some of them into that slot, and it gives us that flexibility to, also allows us to see people on short notice sometimes. So it really is important.
Completely agree. The other aspect of tele that I would speak to is that we don't have a lot of the providers we need, for example, for behavioral health, neurology, infectious disease. So we use teleservices on the inpatient, outpatient setting so that we can make those services available.
I just want to add one comment to this. This is the way we're getting interconnected. We always think of this kind of example, well, telemedicine is a big hospital going to support a smaller hospital by connecting specialty care. For example, at our hospital, we've had a tele-critical care team that helps the care of our patients in our ICU, and that comes out of our big hospital in Albuquerque. But where we've moved as at Espanola Hospital, we've really become kind of the center for addiction medicine, you could say, in our health system, so that we're actually, next month, we'll have the ability for us to provide addiction medicine, telemedicine consultation to other hospitals within our health system, and some of those hospitals are bigger than our hospital, but still, you have to get the group together that can provide these services, and it's not always the big hospital supporting a little hospital. Sometimes a small hospital supporting a bigger hospital, because that's where we have the services available.
And part of the question was, is it financially viable? A clinic work is doesn't make a lot of money, but when you're hospital and you have that they order lab work for them, or they order other things, other radiology exams, that whole balance of that work is what keeps us afloat, but not the one visit.
Not everyone has to answer every question.
I'd say that even in LAMC, I think it has allowed access to care, because in LAMC, so many, I think more than 50% of the specialists are tele specialists. So they have tele-neurologists, they have tele-behavioral health, they have tele-radiologists. So as many as possible, there are a lot of people who are able to consult with outside people, so which is helpful, because then people don't have to drive off the hill to access care if they're having some kind of an emergency.
As an emergency physician, we've relied on telemedicine services for some specialties for years, and probably the most obvious or most pronounced for that is actually teleneurology, and it's really come into stroke care, where sometimes just every second counts, and we need to be able to, and sometimes we don't need the neurologist to weigh in. We know what we're doing, what we got to do, but there's so many different ways. Like, for example, strokes can present in a variety of comorbidities and how it affects the decisions we're going to make, and sometimes to make sure we're doing the right thing, we're able to consult a teleneurologist, but that means also putting a camera. It's an expensive system. You got to make sure we can have the neurologist looking directly at the patient through one of these telemedicine carts, which are not cheap. So.
Our next audience question is, what is being done or should be done to directly address physician burnout here in our community and in our region?
One of the things that Presbyterian does is they have these classes they offer, or weekend retreats, where they have a group of them get together, and they have a behavioral health person there that helps them go through talking about how they're doing, how they're feeling, things that they can do to improve on their work life or their home life. I can't remember the name of the class, but anyway, but we do offer, and then the other thing that we do is we try to make sure that we're keeping up with work-life balance. And so I I've been at Espanola Hospital for 41 years, and I can remember, a doctor covering like the whole month on call for something, right? And then it went down to, they were covering 10-day, 2 doctors were covering the month, and then it went down to 10 days of calls. So then there's 3. And now it's like, most of them are trying to get down to 8 days call a month or 6, right? So
I think there's 3 levels of how do you address burnout in the workforce, and particularly for physicians. It definitely includes providing the support and resources they need to navigate some of just the daily challenges of life, right? The next would be creating collegiality moments where you're bringing together the colleagues just over social hour just to be human. And we make those fairly regularly happen, and people really like to loosen up. It's really good to see it. But then the third is to keep them connected to the purpose, their purpose, and create opportunities for them to grow professionally in ways that they'd like to grow. So, for example, for the last 3 years, we've had a physician leadership cohort driven by the physicians where we have a year-long program for those that would like to take on section leader roles or become members of the medical executive committee and actually go through a whole cohort with their colleagues for their own development. We're actually starting another one this Friday. They've all gone through this DISC assessment, and they're going to be doing dyad partnerships with their clinic leaders and their operational leaders so that they can go through it together, because part of the challenge is knowing that you're not in this alone, right? And so these kinds of programs allow them to know that, I call it leadership, because we're doing it together. And so they're having an opportunity to do some leadership learning. And it's been really sweet.
When you talk about providing tools, one of the biggest concerns related to burnout is that, after they see their 25 patients in a day's time, they now have to go document everything that happened, right? And so we've provided them with an AI tool that records their visit and then types it up for them, and they just check it to make sure it's accurate. And the doctors now are saying that they can now go home by 5 and their charts are complete.
Of course, she's not referring to me when she says that, but I want to address something really kind of different that made me think about, which is the culture of the organization. So you can hold events and you can do retreats, but what really keeps physicians wanting to work in your organization is feeling like they're making a difference, that they're able to grow their practice and meet needs of the community and needs of their patients, but also that they feel like they're part of family at the hospital where they work. And now, granted, I say this as someone who's always worked in kind of a hospital-based program, but I'm sure this is the same in a multi-specialty group practice or a multi-specialty group practice that's integrated into a hospital. But just to give kudos to the leadership at Espanola Hospital, and I've been in practice for 30 years, and the retention of physicians is really amazing, and retention of our nursing staff. By the way, that's another huge bit. Is we want to keep your physicians, then retain your nursing staff that they work with all the time, because one of the things that burns you out, for example, as an emergency physician, is every time I go to work, there's a new set of nurses that I have to learn and know who they are, what their training is, and their background. And so by retaining your nursing staff, it really helps you retain your physicians. But having a collegial work environment. And at Espanola Hospital, I know it sounds like I gush over this hospital, but it really is. It's been a great experience. And because we have just this really collegial relationship with each other as emergency physicians, with our hospitalist group, with our surgical and our other subspecialties, and really administration and with nursing leadership, that I feel like we're always able to sit down and work through problems. So that's what makes you enjoy going to work in a hospital. I've worked in other environments where that didn't exist, and I felt like all I got was this numerical report card every month. Did I see enough patients? Did I code the patient right? Did I generate enough RVUs? Whatever. And that seemed to be the only feedback that I ever got. So.
Yes, again, in a small clinic, I'd say as a physician, when we've had burnout, it's part of it is because of paperwork and administrative burden because of the notes that we have to complete, because of all the coding that we have to do, because of all of the difficulties which we have in terms of prior authorization. So it seems like it detracts from proper care of our patients, which is something that we didn't sign up for. We feel like we want to just come and we want to be able to take care of our people, but then there's all of these things. Like I said, we want to do so many things for our patients, but we are not able to do it. Secondly, I think there was the litigious aspect of it, which caused a lot of people in our practice, for example, to leave. So we had 3 people leave because they had lawsuits, and one was younger than 50, unfortunately, and he just got burnt out because he was sued for something that he didn't do wrong, really. So that is another reason. And thirdly, I feel what helps us not get burnt out is selfishly, all of us, all physicians, want to have a relationship with our patients, and having that kind of a camaraderie and seeing that the patient is a patient, which is why it's so nice to be able to practice in Los Alamos, because then you get to know the patient, you get to see their spouses, you get to see their children, and you get to see the whole family. So I think what keeps us going as physicians is, I'd say, the relationship that we form with our patients, which selfishly keeps us happy, and we feel that we've made a difference. Because if you come to work and you feel like you really haven't made a difference, and the patient is mean to you, and somebody came today and threw the card at our receptionist's face and left, and so these are interactions then which make it very difficult, and you feel like, what am I doing here? But if at the end of the day, even if it's a small word of kindness by staff, by leadership, by our patients, we feel like, okay, we have the energy to come back tomorrow.
Thank you, guys. So our next audience question is, the disabled community has issues attending these meetings. How do you plan on reaching out to that type of community? I don't know if everyone can hear you.
Yeah, telemedicine is an enormously important resource that's enabled us to take better care of our patients who are disabled, have difficulty with transportation, don't have family resources, all of those things. But as we mentioned earlier, it's not a cure-all. There's still a lot of gaps with the telemedicine concept, and I can't draw somebody's blood by telemedicine, and I can't, I can't send the X-ray machine, into their home. So,
by regulation, our facilities have to be set up so that they can accommodate patients with disabilities, and so I would guess that we can accommodate that. But if at any point in time you see, hear, or think otherwise, just let us know, because sometimes we're not aware of that.
And not only disabilities from everything physical, but we have to provide an interpreter service, for example, for deaf patients. We have to have an interpreter service for all patients. These are all, once again, expenses that the health system bears. But a lot of building code and everything, parking and all those that we do to make sure that disabled patients can access care.
The next audience question is, what are your thoughts about court-ordered meds for substance abuse, for example, Vivitrol and naltrexone? Yeah, I was like, there you go. We have the expert in the room.
So actually, there's a difference between, I think, sometimes court-ordered medication and giving individuals an option to get substance use disorder treatment rather than going to jail. So there's a variety of topics that come out of this discussion, right? So there's programs in Rio Riva County such as Reroute and LEAD, and which really give us the opportunity to see patients for their substance use disorder rather than having them incarcerated. And by the way, if you want to know who is the largest provider of behavioral health care in the United States, it's the penal system, right? So, and sending somebody to jail with a substance use disorder rarely cures their substance use disorder, right? But so it is something that's been really important, and we're growing that collaboration with our court system and with other resources in our community. But as far as like medication specifically, medications for substance use disorders work if somebody is ready for help with their substance use disorder. So if they really don't want assistance, the medications are going to have a limited amount of benefit. And there actually is, so I think it's great to have sort of court-ordered, so to speak, opportunity to meet with an addiction specialist and our care team, which is peer support workers and counselors and our nursing staff. It's not something just the provider does by himself or herself, right? But some medications we ordered actually can do more harm than good. Specifically, naltrexone. So naltrexone is a wonderful medication. We actually use it predominantly to treat alcohol use disorder. It was not created for that. It was created, although it is FDA approved for that. It was created to treat opioid use disorder. And so what it is, it's a long-acting form of naloxone, which we use like to reverse overdoses, and it doesn't satisfy cravings. It just blocks opioid receptors. Now, it works in a completely different mechanism, and it does reduce cravings for alcohol, and it can be very effective as long as the patient wants to get better. Doesn't work universally for everybody. It has a very high rate of assistance. So, but where I've seen the most dangerous aspect of like forced long-acting injectable naltrexone, the brand name is called Vivitrol, which really is it's a wonderful medication. It's been particularly dangerous for adolescents. And the reason I say this, I'm trying to get too technical on this, but if a lot of folks think, well, we don't want to give adolescents what we call an opioid, right? So we use opioids such as methadone, and we use opioids such as buprenorphine, which is a partial agonist opioid. And these are the cornerstones of agonist therapy for opioid use disorder. And so I also, by the way, I'm a medical director for an adolescent facility in Albuquerque, one of the two in the state, actually, that provide adolescent withdrawal management and such. But sometimes we think, well, we just need to give them this naltrexone that blocks these opioid receptors, and that's going to be better because it just seems bad to put them on an opioid agonist such as buprenorphine. Well, the truth is, it kills more kids than it helps in a lot of ways, and the reason is you force a medicine on them that doesn't take away their cravings, and it just blocks the way it satisfies the receptor, blocks the receptor. The receptors get downregulated, the patient continues to crave, and then they keep trying to use, and when the medicine wears off, they use and they have an overdose because they no longer have that tolerance. So these are programs that sometimes can be well attended, and they have to be very carefully thought out.
This one is this person was kind enough to give a kind of a backstory on why they chose this question. But pediatric psychiatry care is sorely lacking, both outpatient and inpatient. The current answer for the entire state hospital system is to ship them to one hospital, Mesilla Valley and Las Cruces, or send them out of state. Los Alamos has a higher than average pediatric psychiatric need. How are all hospital systems working to address this severely concerning social determinant of health?
So at Presbyterian Espinal Hospital, we're recruiting a psychiatrist, and we have interviewed several psychiatrists, and interestingly enough, several of them have been both child and adult psychiatrists. So it seems like there's more doctors getting into treating both children and adults for that work. But I agree that we need more of them. We were able to hire somebody part-time that'll start in October, but we continue to look for another full-time provider.
So I'll try to keep this shorter than my last answer. Yeah, there is definitely a dearth, a shortage of access to behavioral health, to psychiatrists. What we're doing regionally within Presbyterian sort of has a sort of Albuquerque-focused system, and then a lot of rural hospitals that work together. and collaborating with other rural hospitals, in fact. So, for example, Brenda collaborating with the hospital in Ruidoso to think about how it's going to make it easier to hire psychiatrists. And if we can put our resources together, once again, smaller hospitals, but working collectively to help recruit and making sure that if you hire a psychiatrist, they're not alone, that they have a group that they can collaborate with and work amongst. And sometimes that means, psychiatrists between multiple small hospitals getting together, sharing resources, collaborating. And so the hospital in Ruidoso just actually hired an adolescent and child and adult psychiatrist. And so once again, our psychiatrist and that psychiatrist, that neither of them have started working yet, but they're already talking all the time and thinking about how they can build this network of care to help.
And Presbyterian has an inpatient adolescent center in Albuquerque at Caseman. And I think, do you have, no?
We have an adolescent behavioral health specialist in our emergency department, and then we have psychiatric support in our clinics and can also help in the pediatric clinic. But we don't have the capacity to do adolescent psychiatry within the hospital. We have a fairly substantial adult behavioral health program as well as a observation unit for behavioral health, and we really are at capacity. That is our wheelhouse, and we don't have the capacity to go beyond that.
And most ERs, to include ours, will have behavioral health via telehealth in our ER if a patient comes in that can assess those patients and help us determine what the next steps should be.
Our next audience question is, why are no PCP at MANA accepting Medicare? The person who asked the question said, after Dr. Church retired, I have been seen by many other PCP and PA, and now I am told that there is no where I can see that will accept Medicare.
We are accepting Medicare, so I don't know where they got the information from, because Manam is accepting Medicare. It's true that we have had problems with retention and because of the other reasons that we talked about, but Manam is accepting Medicare patients.
The next question is, how does remote patient monitoring play into the practice?
At Presbyterian Espanola Hospital, we have telesitters, for example. And so Presbyterian has employees in Albuquerque that monitor these cameras for all the Presbyterian facilities. And so we assign those rooms with cameras to patients who have a high risk for falling. And this new AI software has like bed rail parameters around the bed, and once the patient exceeds that area, the alarms will ring and the employee in Albuquerque will call our employee. So that's one example.
We also have telesitters. What we are going to explore on the outpatient setting is remote patient monitoring for people on a cancer journey, so that they can be monitored from home after they've gone through certain therapies. And so we're in the very early stages of that, but given the preponderance of cancer, we're trying to figure out other ways to come to the patient.
Right. This next question, I think, plays a little bit into the last question, which is about biometrics. Does telehealth use biometric scans as well? Just no. That's totally fine. That is totally fine. So then our next audience question is, how do you plan to offer treatment to NAS babies, youth with neonatal absence syndrome at their and their families at your renewal clinic? Some of these may be directed to specific people here.
No, that's okay. Actually, we have working in several ways to improve our care of pregnant women and of newborns who have substance use disorders. And the part of forming our group of physicians, in fact, we sought out an eclectic group. So, for example, to get boarded in addiction medicine, first you have to complete a residency in another form of medicine as a primary field, and then you used to be able to to accumulate enough hours of experience. And so for a board exam, now you have to complete a fellowship to be able to get the board exam. And so amongst our 4 physicians we have currently, so my primary background is in emergency medicine, and Dr. Gregg, who's amazing. She's in internal medicine. Our young doc in the group, Dr. Nahera, just recently completed his fellowship at UCSF, and his background's in family medicine. And Dr. Fox is a pediatrician. So her background's in pediatrics. She's doing adult addiction medicine, but her passion, of course, is caring for adolescents. But also part of this expansion, and it's a process we're now working with, is our newborn care. Actually, our nurse practitioner in our group, before she became a nurse practitioner, she was a neonatal ICU nurse for 11 years at Christus. So partnering also with our pediatricians, we have we're fully staffed with 3 pediatricians now, 3 full-time pediatricians, and our pediatric hospitalists. So now we have to, over the next few months, really map out how we can keep more of our newborns with us. And while we can transfer the newborns sometimes to Christus, sometimes to Press Hospital downtown in Albuquerque or UNMH, the reason we try not to, or we're going to try to transfer many fewer, is, and I will say this, is basically getting back to what we were able to do kind of before COVID, before fentanyl, because we actually did keep a lot more of our babies. In fact, Dr. Hayes, Leslie Hayes is in the audience, and she was a big part of keeping those babies with us at Espinal Hospital. So we lost some of our providers, and so we didn't have the physician expertise necessarily, but also the conditions became more difficult. So this is going to be a model of working with our nursing staff, finding out what we need to be able to do more. Do we need to be able to do more gavage feeding, et cetera? And I can tell you, I don't want this to sound like it's the wrong focus, but my main interest in keeping the newborns with us as long as possible is to have them closer to their families so their families can visit them. It also means we get to keep mom. So when we keep the newborn, mom rooms in. And this is, by the way, a lot of the work that actually Dr. Hayes has pioneered in our state. But having mom room in, using better scales for monitoring withdrawal than what used to be used. And if we get mom to stay with us, we get to get mom into treatment. That's the driver in a lot of ways. It's really about helping the whole family. But when we have to transfer the newborn, unfortunately, mom's now an outsider. And so if a baby gets transferred down to Albuquerque, mom can't room in, right? And the family, it's hard for them to visit. And mom has to try to get treatment around Albuquerque, when she's immediately postpartum, and it's really challenging. So but when we can keep those babies longer, it not only is it good for the baby, but it's really good for mom and for us to help mom and the family.
Our next audience question is, we have lost nearly every single non-emergency transportation company throughout the entire state. This puts a huge strain on helicopter agencies to where 80% of their calls are now non-emergency transfers. 99% of New Mexicans cannot afford this. What is the answer to the supplement grant transportation other than just to rely on local fire departments?
We own and manage the EMS service for Rio Arriba County. It's a 911 response team. And we have committed to have 2 trucks to do that work. And we then brought in we now have a 3rd truck that can help us with transfers. But, it's just enough. Like last night we transferred out, I think, 9 patients, right, in 24 hours. And so when you assess the time it takes for our crew to get all the way to Albuquerque and take the patient all the way into one of the hospitals, give a report, come back out, get back and gas up and clean the truck and get ready for another patient, we're calculating 5 hours, right, turnaround time for the 1 truck. And when they go to St. Vincent's, we're calculating 3 hours for all that effort. And so there just isn't enough ambulance folks or crews to be able to take all the patients' interfacility work. And so we do work with other ambulance services to try to get patients out. So we work with Albuquerque Ambulance, which is owned and managed by Presbyterian. Helios, we use AMR, we use like every service that you could think of, right? Unfortunately, most patients need to all be transferred around the same time. It's around in the evening. And so we balance delaying care versus, getting them there as quickly as possible. So it depends on the presentation of the patient and the resources that are available for them wherever they're going. So for example, Presbyterian ORs are really full Monday through Friday with elective cases. And so when you have emergent presentation going in that needs surgery, a lot of times the only surgical time they have is in the middle of the night, right? Or in the evening. And if it's emergent, they need the surgery right then that evening, right? So we're balancing the number of patients, the patient presentations, and the beds available, whether it be at St. Vincent's or in Albuquerque, to get that done. But we are committed to do the right thing for the patient, even if it means a helicopter, and then trying to figure out how to navigate the cost of that later.
Similarly, we work with 3 different ambulance services, but I will tell you that transportation of this type is in the top 4 for hospitals in New Mexico. We don't have enough crews. We made several efforts for legislation for education training programs for these type of young persons, ambulance services themselves, and then the environment, the liability environment for those services is often a challenge. But this is a huge rural New Mexico issue.
Just add a couple comments as an emergency physician, to that. We have more ambulances than we can staff. So we have multiple trucks, as we call them, or rigs, we call them, but that's our challenge is getting them staffed. And as one who provided medical direction for multiple EMS education programs, community colleges, et cetera, this is an underfunded area as far as secondary education in many states and in New Mexico. We do need more EMS training programs, and we need to be able to afford them, right? Because they don't necessarily pay for themselves; they're challenging.
The next question is a question for Chris St. Vincent in regards to the silver tsunami. I'm wondering, what is Chris's plan for expanding the Center for Healthy Aging as people plan to age in place in Los Alamos?
That's a very good question. We haven't talked about the expansion of that particular program into Los Alamos yet. We are definitely expanding our primary care services to include, I think, orthopedic this month. We're going to have additional cancer oncology support here, but we have not moved into that geriatric or elder care space yet. Doesn't mean that we won't. We have started embedding that work within the primary care clinics within Santa Fe, and that's sort of our toe in the water to then expand into the clinics that are outside the Santa Fe area, but we're in the very, very early stages.
Thank you. So our next question is, do you have any plans for home health care? Right now, none of the 6 agencies serving Espanola to Taos have home health aides, and there are often long waits for nursing IPT/OT.
So Presbyterian is managing home health services for all the Presbyterian facilities and communities. And so the home health care staff for Espanola patients and North, and apparently to Los Alamos also, is coming out of Santa Fe, so out of the Santa Fe office. And I did ask if they were planning on expanding it now that the local home health service is closing, and they said they will be working on it. So they said if you have a need to call. That's how we grow, right? Yeah.
It seems like our possible last audience question is, will any of you be increasing what documents you share into Synchronous to help patients getting care in so many different systems?
Synchronous is a software, I assume. I haven't heard of it, but
Yeah, so Synchronous is a key software for the HIE, the Health Information Exchange, and this is actually a key part of the state's efforts, particularly to improve behavioral health care and access to substance use disorder treatment. So Presbyterian does participate in Synchronous. Where it helps us is not necessarily the physician part of the care, but in connecting people to residential treatment, to counseling services, and kind of the ancillary part of substance use disorder treatment, for example. But it is expanding. It's Synchronous replaced a previous software product that was much clunkier and really, even though we tried to force hospitals to get into it and use it, load information, it wasn't very user friendly. And so I think that the Synchronous project is going to be very helpful. Thank you, Leslie.
I didn't look to the back of the cards. We have one more audience question. I didn't look to the back. Our possible last question is, how long do you think it will take to see our doctors and nurses return to Los Alamos, Espanola, and Santa Fe? This plays back in now, I guess, to the 1 to 5 years from now challenge question.
well, so I was thinking this through on the weekend, and I thought, okay, so how did the med-mal costs go up, right? It's the companies that we use to insure us, their employees, their actuaries are running the numbers, and they're saying, oh, we need more money, right? We need more money to be able to cover you based on what's going on in the state of New Mexico. And so one would think that as the new law goes into effect, would that be July? So then one would think that the actuaries would run the numbers again and start decreasing those costs. But I also think kind of works kind of like when we buy a house, right? And so if the house next to you sold for a lot more money, the cost of your house went up. But I don't know that they necessarily start.
I do think, though, the narrative is shifting, right? I think this message with these big pieces of legislation passing signals to providers and others that we're open for business, that we want to hire great providers to take care of our communities. And I think they're going to be much more open to that conversation now than ever before. I think I can say on behalf of Brenda and I, we have teams that work pretty aggressively to recruit and retain. And one of my key takeaways coming out of the pandemic is they knew what it was like to work in the big, crazy cities and do heavy workloads. And they came out of it thinking, you know what? I want to work where it's a beautiful place, about smaller communities, and have more work-life balance. And we've been very successful on the recruitment front in spite of the medical malpractice challenges. But I think we'll be more successful now that the New Mexico narrative is changing to be more supportive of healthcare, of health systems, of providers, of nurses. So I'd like to think that we're going to start having more of those conversations with these providers, more so in the next year. I think we'll see the benefit, at least 2 to 3 years out, because they have to, have their own separation agreements from wherever they're at and the time it takes to bring them here and get them settled in. But I think the doors are open.
And up to this time, there was a limited number of insurance businesses that were willing to sell med-mal insurance in this state. And I think that now you'll have more options for med-mal insurance.
And I think the biggest selling point of Los Alamos has always been the community and the schools. And so we always have wanted to attract young people. And the fact that there's going to be the assistance with loan repayment is what we are hoping will be able to attract young people or doctors who are out of residency to come, because Los Alamos does offer a great work-life balance. So we too, in private practice, are hoping that we'll be able to retain, or rather recruit, more providers, both nurse practitioners as well as physicians.
So thank you all. As we close tonight's conversation, I want to thank our panelists for their leadership, candor, and their deep commitment to Northern New Mexico. So please give a round of applause for them coming out tonight. The challenges in healthcare are very complex, but what we've heard tonight makes one thing clear. We have dedicated people across our region working every day to strengthen our systems and serve our communities. Thank you to our partners, Los Alamos Community Foundation, Anchorum Health Foundation, League of Women Voters Los Alamos, our volunteers, and all of you for being engaged and informed citizens. Conversations like this are how process begins. Please have a wonderful evening and continue this dialogue beyond this room. Thank you all again for coming out tonight.